Hello and welcome to the Dementia Doctor. Today we are going to discuss an important aspect of Alzheimer's disease, specifically when we test for Alzheimer's disease with a PET scan or an amyloid test. And if those test results do not agree, what should you be doing? So we will start with some scenarios that you may have run into the clinic. Say you see a 77-year-old gentleman who is having memory problems, forgetting conversations and names for the last 4 years, and you do a PET scan that is positive. You do a CSF or a spinal tap that doesn't is not consistent with Alzheimer's disease, and then you do a blood test as well, and this one is indeterminate. So, what do you do in such a situation if you have one study that suggests that they have Alzheimer's pathology, another test that suggests that they don't, and hoping that you would get some answers with the blood test, but that is also indeterminate? Another situation that we commonly see in the clinic is you have someone that is being referred for assessment if they would be a good candidate for the new anti-amyloid infusion therapies. Now, in this case, confirming that they have the Alzheimer's pathology and amyloid is very important, as we are planning to treat them with the anti-amyloids. So in this situation, say the PET was negative, but the CSF was positive, and they were seeing another primary care, another neurologist before they saw you, and their blood test was also positive. Now, in this situation, which test would you choose to be the right one or the ground truth? How do you know which one is more accurate? Do you go with the pattern? Oh, well, two tests are positive, so maybe they have Alzheimer's disease. Or do you look at the fact that one test was negative, and it doesn't make sense that they are not agreeing with each other? So, questions like this are something that I've seen the field as we are having the new biomarkers available. I've seen people and clinicians and neurologists struggle with these questions as these are available, but there are the questions about discordant biomarker results as well as discrepancy has not been something that has been addressed. So it's a question for you. What would you do if you were the patient or the physician? But essentially, it's not a trick question. It has not yet been addressed in the field. We still do not know what to do, how to deal when you have two biomarkers that do not agree with each other. So, but I've seen people kind of solve or work around or struggle with this problem. So what I've seen them do is they will say, well, CSF is more sensitive because you're getting fluid from around the brain. Or they will say, well, one of them is positive. So I will choose that to be the ground truth because having a PET scan positive is an important enough evidence. So they just choose one of them as ground truth. And as we go through the talk, I will kind of walk you through that reasoning that we do not have enough data or backing to choose one test as the ground truth. I've also seen people say, well, let's repeat this test in 6 months and see if your PET also becomes positive, or your CSF also becomes positive if there's a discrepancy and then there's a confusion and the clinical picture is also confusing. So they say this is a test of time. Let's see if one of the tests was not yet positive and will be becoming concordant with another test that was positive. I've also seen people, if they've already gotten two biomarkers, they use the third biomarker to get kind of a tiebreaker situation. Again, we do not have data for that to do that kind of testing. And we will walk through all of that in the coming slides. Now, this got me thinking, we do have three biomarkers, right? And why do we rely on one? And why cannot we use the pattern instead of relying on just one biomarker? So I thought of designing a study where I can get information for the same individual who has had a PET scan, has had the lumbar puncture or the CSF, and has their blood drawn for the amyloid. And what I found was there is the ADNI data set. We are all very familiar and grateful for this data set to exist, where you can find information for a single individual and multiple such individuals who have had all the three testing done. So we decided to have a study design, which was a cross-sectional secondary analysis of in a subset of population for the ADNI data set. We did find about 320 patients who had these all three biomarkers that were done for them. Pretty exciting, right? Um, and it is going to be published pretty soon. It is in preprint, and I will also share the link below in the description. But before we even go into that, the question arises, what are we measuring? What are we trying to, or what do we think we are measuring, right? There are three tests. What are we doing with them? Are we measuring amyloid? Because that's how they are being kind of designed and marketed. Are we measuring Alzheimer's? Of course, we're not measuring Alzheimer's. We are trying to get to that diagnosis of Alzheimer's disease by measuring these biomarkers, right? I have the picture of Dr. Alois Alzheimer's and Auguste Dieter, who was the first patient with Alzheimer's disease described. And this is something that we will keep visiting, how important it is for patients to have symptoms before we think about these kinds of testing. So, what is Alzheimer's disease? Well, there are two kind of not fully agreeing definitions for Alzheimer's disease. One is by an Alzheimer's Association collaboration, and they say, well, if you have amyloid, you pretty much have Alzheimer's disease. There's also a mention of it doesn't matter if you have symptoms or not. And then there is the International Working Group, which is another expert consensus, which says you gotta have your amyloid and tau, not just amyloid. And you also gotta have the person to have the disease. So are you saying that for the disease that is the bread and butter for someone who works in a memory clinic, we do not have a definition that the experts agree on? And are you saying that individuals who are trying to help treat Alzheimer's disease are working with that amount of uncertainty? Absolutely, yes. We do not have an agreement. But if you ask me, do I have the courage to kind of look at all the data we have and say, because these are both expert consensus based on all the data. So they're not studies by themselves, they are expert consensus. So can we also ourselves look at the data and see which one makes more sense? Why not? It is the International Working Group definition, which says you need to have amyloid and tau. We have known for years and years and years people can have amyloid in their brain and they may not develop the disease. So just having amyloid is not sufficient. Number two, you got to have dis-ease. It's in the name. You cannot call someone to have a disease without them being not at ease. Alzheimer's disease. So let's move on and kind of come back to our question, how do we detect Alzheimer's pathology? So we have these three biomarkers, okay? And we are looking at amyloid in the brain. But what is the ground truth? We've just talked about Alzheimer's definition. We've just reasoned out that you need to have amyloid and tau in your brain. So this is a cartoon representation of someone who has Alzheimer's disease. The yellow or the yellowish brown circles represent the amyloid plaques, and the pink, magenta, MASH-like structures show tau in the brain. So brain on the left is a healthy brain, and the brain on the right is is a cartoon representation of how a person's brain with Alzheimer's would look if you looked under the microscope. So amyloid and tau both are necessary, and this is the ground truth. In reality, if you look under the microscope, the picture on the top, which shows a plaque that is again in the yellowish color, and it is consisting of amyloid as well as dystrophic neutrites around it. That is when amyloid deposits and the parts of the brain cells also react. There's inflammation and tau starts forming. And the picture below, the pink picture, this is about the tau tangles. Just like the name sounds, they are tangles. Now, as I said, if you're thinking about ground truth, who has Alzheimer's disease? You take a tissue off the brain, you look under the microscope, and you find amyloid and tau. And the brain, again, this is a representation, would have amyloid and tau, and that's how we would have 100% certainty of someone having Alzheimer's disease in the right clinical context, right? They should have the symptoms as well. And this is the best and the gold standard way of diagnosing someone with Alzheimer's. But of course, we are not someone who can go on and take biopsies from people's brain who are living. So that is why we rely on biomarkers. We look at a PET scan, we look at spinal tap, or we do blood test. And these are proxies of that ground truth. They are not ground truth. Not a single one of them is the ground truth. They are proxies. But for the sake of our discussion, as we say, in this particular talk, we will be looking and focusing on the amyloid detection and the biomarkers for amyloid. So before we even go into that, how are they validated? So I said, they are kind of proxies or estimations of ground truth. They themselves are not the ground truth. So when the PET was developed, how did people validate? Because as we said, you truly need a biopsy of the brain and you need to look at the brain under the microscope to diagnose with Alzheimer's disease. Well, they did validate it with some people who had PET scans during their life, and when they passed away, their autopsy studies did show deposition of neuritic amyloid dense plaques. So that's how the PET scans were validated. They were compared directly against the gold standard, that is the brain biopsies. Now, what about CSF? Well, it was compared with the brains and the brain biopsies, and there are studies for that. But the FDA approvals primarily in the beginning, and all these are the numbers below. You can look up these studies for yourself. They are very detailed. It's a good read if you're really interested. The DEN and the K numbers, that is what I'm referring to. These are the FDA regulation for the CSF, the spinal tap, and it was done against the PET scans, okay? And then we go on to plasma. This was very exciting that we had the first blood test that was cleared by FDA again compared against CSF. We do have plasma tests that are also compared against the PET scan, but this one was against the CSF. I have another talk on my channel regarding this, going into detail about this approval. This was a very exciting approval, but and as I said, we had the validation against the CSF and the PET scan, but because the blood tests are validated like this, the results never say, even if it's positive, right, for the blood test, it doesn't say you have Alzheimer's or you don't have Alzheimer's because they cannot say that. So the results say This test gives a higher likelihood that this patient will be positive on the amyloid scans. Some of my patients have asked me, why is it worded like that? What does it mean? It's so confusing. Well, it is worded like that because that's how it was validated and studied. And they cannot claim, and they're not claiming that they're diagnosing you with Alzheimer's disease just based on a blood test. So this is very important. And as we move on, and as we uncover the fact that we had the ground truth, right? The brain biopsies, and then we validated the PET with the brain biopsy, then we validated the CSF with the PET scan, and then we validated the blood test with the CSF. So, of course, there are other parallels, and we have had studies with blood test also being validated with the PET scan and CSF also being validated with the brains. But overall, this was how the Alzheimer's biomarkers were developed. And as you may already be thinking and wondering, wow, that's a lot of errors accumulating at each step because every test has its limitations, right? There is no test that is 100% sensitive and 100% specific. When we get a PET scan or a CSF or a blood test, sometimes they may be incorrect. And that's what we try to minimize for our families and patients. So, if we kind of summarize what we have discussed so far, is that these tests are estimations of ground truth. They are not the ground truth. They are imperfect estimations of ground truth, right? Because they have their own limitation. Each test has its own limitation. It's not 100%. We cannot, with the current data we have, and again, a lot of things that we talk about, this field is evolving so quickly, this may change. At present, we cannot force them to be the ground truth. We do not have enough data to say, well, the CSF is truly better, or well, the PET scan is truly better. At present, we don't have enough data to say that. So I cannot truly say that when I have a patient who has two test results that do not agree. How important is this? Think about it. Errors accumulate if you validate one test based on the other test and the other test based on the other test and the other test based on the other test. Each test has a limitation. It will be kind of increasing, multiplying, and increasing as you go to the next test. So, what about if they are discordant, if they're not agreeing? What do we do? So the question, again, before we go into that is, are they measuring the same thing? Well, what do you mean? I just said that they're measuring amyloid. We're looking at amyloid. But do they measure the same kind of amyloid? Well, not really. So when the amyloid forms, it starts with small fibers. These fibers start accumulating. Some types of fibers are soluble and some are actually sticky and they remain in the brain. The PET scans are designed to measure a specific type of plaque, not even all the plaques. It is picking up your dense neuritic plaque, a dense amyloid collection with the tau around it, or with the neurons that are starting to inflame and have tau around it. So, in a way, actually, it's pretty good if you think about it. It has the amyloid, it also has the tau. It's a great test if you think about it that way. But if you look at CSF, it is measuring the soluble protofibrils, another kind of structure that is in the path to form the fully formed amyloid plaque. So they're not measuring the same thing. Biology in this case is not the same. Yes, it is the same process, but it's not the same. So now we come into conclusion with our discussion that these are estimations, they are imperfect estimations, and there is not one test that could be thought of as the ground truth. And errors accumulate, and they don't measure the same exact structure or same exact substrate in the brain, although they're both trying and claiming to measure the amyloid protein. This is a pretty difficult problem to solve. But in front of us sits a patient, and they are struggling. And as clinicians, I think one of the most helpless situation is when you cannot figure out or help your patient. There's no feeling that can pull a clinician down, except that low feeling where you know that something is wrong. You're trying to help them, but you're kind of in a situation where you're limited by the test, right? But this is the age, this is the day where we have therapies available, where we have to learn how to use all these biomarkers to our greatest benefit. And we got to do something for our families. Imagine having these tests. Imagine having a discordant test and not knowing whether you have Alzheimer's or not. That's not a good place to be in. So we got to do something for our families. Now, this brings me back to the study that we designed. And what we did was we did find individuals had about 608 triads. So some individuals did undergo their amyloid PET scans and CSF and blood tests done multiple times, right? But we wanted to just have one triad per patient, because otherwise, it's not scientifically as good of a study if you take multiple numbers from one patient. So although the total number of triads for these studies was 608, we only chose one triad, one triad meaning one PET, CSF, and blood test from one person. So because there were 320 people, we had 320 as the number of triads we had in the study. And we also looked at what kind of data is available. Because yes, I say CSF, I say blood, but what exact tests were available? So the PET scan, which was available, was by the visual read, whether it's positive or negative. And we anchored the time point to the PET scan, and we said what was the closest CSF and the plasma test to that, because we had to find an anchor, right? And for the CSF, we chose, which is the part of the data set, the Alexis A beta 42/40 ratio. And we had some participants who had the A beta 42/40 ratio for the blood test, and some had the p tau 217. For this was for the primary study that we designed, and then the coverage analysis, just to check if everything is making sense. We had some participants that only had the CSF Alexis A beta 42 and did not have 42/40 ratio. Again, we do know 42/40 ratio is better than just having A beta 42. I've talked about it in my previous video when I've gone over the blood-based biomarker and the FDA approval. Overall ratios are a better way to look at these numbers. Now, we are still facing this big problem, right? And how do I choose one, and how do I compare the other biomarkers? What do I do? This is a big problem. And it's not an easy problem to solve, as you are already kind of deep into the problem with me thinking about it, thinking through it. So we had to look a little beyond, and we looked at Bayesian statistics and Bayes' theorem. So this is a gentleman who talked about probabilities when we have situations like that, when one part of what we're trying to deal with is truly hidden. So this is the formula. And it reads as posterior probability is equal to likelihood times prior probability divided by evidence. I promise I will walk you through this formula and you will understand this formula. But let's first understand the concept. What are we trying to solve? Why did we choose this particular statistical modeling to solve that problem? So as I said, the amyloid status, we're trying to answer the question about amyloid. It is hidden. Whether someone has a brain without amyloid or they have a brain with amyloid, we truly do not know. It is hidden. And that is the ground truth. So, ground truth is hidden. I have no idea in a person who is living, who has not had a biopsy, to know whether they truly have amyloid or not. And it is important to acknowledge that. It is a latent state. I do not know what is the true status there. Now, since we do not know what is the true status, and we say, well, this is a latent or a hidden state, we then look at what data we have to help us, right? So the latent state is we do not know the ground truth in the brain that is represented on the extreme left, on the pink side of the image, where we are kind of saying, well, we do not know whether someone is positive or negative, but we do have a pattern. That's on the right side of the slide. We have three biomarkers. They will help, but thinking about them as a pattern and thinking about probabilities instead of claiming certainty when we do not truly have the certainty. So coming back, as I promised, we will walk you through what does this theorem mean. So we will look at one term at a time and explain one term at a time to help understand what does this mean. So let's go here. Prior probability. Now, prior probability, all my behavioral neurologist friends will be cheering me up here because this is your pre-test probability. So even before you get tested for anything with Alzheimer's, any biomarker, this is a request to all the primary care, to all the general neurologists, and all the patients I have. This has landed so many people in so much trouble. Please do not test people if they do not have a pre-test probability that is high. That means you need to have a certain degree of clinical suspicion before testing people. You cannot just test anyone who walks in your clinic and says, I have memory problems. Don't do that. It results in people getting so anxious and you're testing them. I've had people who have had ADHD, who've had depression, anxiety. They did not have any clinical picture. They were very young. They were in their 50s. The primary care or someone else tested them with the Alzheimer's test because it was available. But the part that I truly think is lacking is the education, how to use that test so that you do not generate unnecessary anxiety. So far, in the years I've practiced, I've only had 1 to 2% physicians outside my practice using the blood test correctly. 99% of the time is very painful. My patients are very stressed out. The physician was not educated how to test, when to use the blood test. This is one of the very important things. So pay attention here. You gotta have the right age, the right clinical presentation. It cannot just be, I'm having memory problems, and you didn't even ask them about sleep apnea. You didn't even ask them about depression and anxiety, and you didn't even see that their primary problem is attention and not memory. We got to make sure we do our due diligence before we test patients. Just because a test is available, we don't use that test. So prior probability is when a behavioral neurologist or a trained general neurologist in this field sees you and says, well, based on everything, your age, the way you're presenting, your MRI, and all the data I have, I think based on this, there is a high likelihood that there is Alzheimer's disease. Now, this training itself is the part that is not being emphasized by any blood test, by any regulations, which is the problem that a lot of people are being tested without doing this thorough assessment. And this is something which we say, well, what is your suspicion that someone might have Alzheimer's? Even before doing a test. So this is just the art of medicine. You get history, you get information, you understand what's the pattern, how have they developed the disease, what were they having, what are the other things that could have caused it, their memory problems. So this is before the test. That's why it has the word prior in front of it, prior probability of someone before I even tested how suspicious I am that they might have Alzheimer's disease. So that's that term. Now, moving on to likelihood. This is where we say, well, if you are expecting someone to be positive with Alzheimer's or negative, you're thinking that their hidden state, the ground truth is positive or negative, and you have three biomarkers, or you have multiple studies, if you're thinking about just the equation, which pattern fits which condition good? And what is the compatibility, right? And that's where we were thinking about PET positive, CSF positive, blood positive or negative. And you have to think about this in a pattern form. So likelihood is to think about that. Now, evidence, that's the next term we're talking about. This is to normalize. This is just to see what is the frequency of the pattern in the general population and in the population where we are, for this particular case, actually, in the population where we are looking for Alzheimer's disease, what is the expected pattern for people who may have truly have amyloid in the brain, and for the people who do not have the amyloid in the brain, and what is the frequency? So this is to normalize this equation on the numerator's end. Now, posterior probability is, I see a patient in the clinic, I order some test, and how do I update my degree of suspicion based on the test that has come back? So say I was suspecting Alzheimer's disease and the test comes back positive, right? So it increases my probability. So this is posterior after the test has been done, after you've been seeing new information. These are your biomarkers once you've done. And you can imagine the other scenario where you've done that test, you were suspecting, but then the test was negative. So you got to update your posterior probability based on the new information. Or to say it better, you got to update your prior probability, right? You were thinking they have Alzheimer's, the test was negative, and you say, well, oh, I have to update and I have to think in probability terms that they might still have it. This test was not able to capture it. Or probably I need to look at other things. So that's what is posterior probability. So this is the data we got. Now, to look at it, it's a lot of information all together. So let me help you by first just looking at the axis. So on the panel A that is on the left, you see an axis, the y-axis. This is the concordance and the discordance between PET and CSF. Does PET and CSF agree? On the very top, the first thing you notice is it says PET minus, CSF minus. That means that both of them were negative. So they were concordant. They agreed. If you look at the very bottom, it says PET positive and CSF positive. This is also concordant. They are agreeing with each other. The middle panel that says one is positive, one is negative is discordant. This is our area of interest. This is what we're trying to solve in this paper. Now, if you look at the x-axis, it has the terms low, intermediate, and high. So in the ADNI data set, we used the precision test, and it gives the result as low, which means that you have low risk of the PET being positive, and high, which means that you have a high risk of PET being positive, and it has an intermediate number. So for the blood test, that's how it is reported. It's not a positive or negative. It talks about a low risk, a high risk, and an intermediate risk. Okay. And the way so this panel on A is for plasma amyloid beta 42 to 40 ratio. And the panel on B that will appear shortly for you as well is for the p-tau 217, okay? And now we are seeing how do these two blood tests compare if the PET and the CSF agree or if they don't agree. Now, it is a heat map, and what that basically means is we have a color, a rainbow kind of situation going on, where if the probability is close to 1, that is everything matches up, and I am, with that formula that I showed you, predicting that the latent, the hidden ground truth probably is true or positive, it is they truly have Alzheimer's disease based on these tests, then the color will be closer to the yellowish hue. So you see the scale on the extreme right, where if you see on the top, that is 1. So if things agree, there is concordance, and we are predicting posterior probability. We are saying, based on all this data, I do think they actually have amyloid in the brain. If it is predicting to be 1, that's the color yellow. If it is predicting it to be 0, based on all this data that I have with all these tests, I think that I don't think you have Alzheimer's, right? So that will be dark blue. Now, as I said, the top and the bottom are the concordant where the tests are agreeing, and the bottom rows are the ones where they are not agreeing. So we'll look at them one by one for the sake of simplicity, because the full diagram looks like that, and it's pretty overwhelming. So let's look at the situation where PET agrees with CSF. Again, the panel on the left is plasma, amyloid beta 42 to 40 ratio. The panel on the right is p-tau 217. And we have, look at the colors. It's all yellow. So when PET is positive and CSF is positive, the likelihood of having truly amyloid pathology, the ground truth that we're trying to predict, is 100%. It's close to 100%, right? You look at all the numbers, it's 0.97, 0.99, or more than 0.99. And it truly doesn't actually matter so much, as you can notice that even if the blood test says you have low likelihood or intermediate likelihood, you actually have a high probability of still having Alzheimer's disease. So take a note of this. Even though the blood test says intermediate, right? We are saying because PET is positive, CSF is positive, you are having a high likelihood of having Alzheimer's pathology in the brain. Wow, that's a powerful message for us. Now, moving on to the other state, PET is negative, CSF is negative. Well, if you are following the conversation, you might have guessed already that if both of those studies are negative, I would think that the person doesn't have amyloid in the brain. And that's what our model is predicting. It is saying that if those two studies, the PET scan and the CSF, both are negative, the likelihood or the probability of having truly amyloid pathology in the brain is 0. So that's good. It's pretty close to 0. Amazing. That's what the blue color demonstrates. Pretty much making sense. Again, can I direct your attention to the fact that here also there were a very few, the n is very small, right? If you look at the amyloid beta 42 to 40 part, but you could still be intermediate. You could still be tested intermediate. And, these patients show up to my clinic, they're very stressed out, and truly they didn't even have their clinical picture doesn't make sense with Alzheimer's. But you can have the blood test, it's not by itself, and we know that, diagnostic, whether it says positive, intermediate, or high. All it is helping us is to think in terms of probability. It's not diagnostic deterministic. And these are the good examples, especially when PET and CSF agree. Okay, so in those cases, the blood test, yeah, it's an extra piece of information. I'm not excited by it. Even if it's negative, if those two say it's positive, I will think that they do have Alzheimer's pathology in the brain. If PET and CSF are negative, and even if the blood test says high likelihood, I would be looking for other reasons why their amyloid in blood was high. Do they have a kidney disease? What's going on? So this is what happens when there is concordance between the biomarkers. Now, the middle two panels is where you see a change in where you kind of, if you look at the color panel on the extreme right, you kind of land in between, right? And if you look at the numbers, this is where, at least with the amyloid beta 42 to 40 ratio, we actually see that blood test is helping us think about probabilities. Now, I'm not talking about the right panel so much because as you can see, the numbers are low. We only have few patients, just how the data set was. But look on the panel A. Look there. Look at how the colors are changing. We are moving and look at the numbers. So if you look at the very top row or the second row, when PET is negative and CSF is positive, um, the posterior probability or likelihood of amyloid positivity is 19% if the blood test also says that the risk is low. But look at it when, again, the numbers are low, so we have to have, asterisks attached to that interpretation. But look at the full trend. Even in the colors, you see that if you have some discrepancy and the blood test says the risk is high, pay attention to that pattern. Okay, so these are the numbers. Now, the major takeaway is when the PET and CSF agree, we have confidence in saying that we think truly the latent, the hidden stage, the ground truth of having amyloid in the brain is pretty close to 100%. When they say that they both are negative, then also we have a pretty high probability of having the amount of amyloid or ground truth to be zero. So when they agree, when PET and amyloid agree, that concordance is very encouraging. It gives us confidence in diagnosis and saying, well, you've had a PET scan that was positive, right? And you've had a CSF that was positive, and your blood test is intermediate. And you're asking me, do I have Alzheimer's or not in the right clinical setting again? I will say yes, because those two tests are agreeing. Those are very important tests. And when they do agree, this you can kind of not pay too much attention to the plasma. What about discordance? The whole discussion is about this discordance. This throws clinicians and patients in a spiral of anxiety and worrying. Well, the data so far that we have looked at tells us that you have to talk in probability. You have to convey uncertainty to your families. You have to say, well, this is the best information I have. Your PET is positive, but your CSF is negative. Now, that is a situation where we don't have a lot of data. So instead of pretending that one of them is better than the other, or one of them is a better prediction of the ground truth, you convey that there is uncertainty. I do not know yet, but this is your likelihood based on um, the prior probability I have. And this makes clinicians very uncomfortable because and this is something that doesn't miss, this is, there's like a mismatch between basic scientists and clinicians. Why? I'm sitting across a patient. I do not want to say I don't know after doing a couple of tests. But is this my limitation? Not really. This is a limitation of the test, and patients deserve to know. And you also deserve the grace because it's not your fault. There is a limitation with studies. There can be uncertainty that's there. And we say, well, this is the pattern I have. I have a PET that is negative, CSF that is positive, but your blood test is saying high risk. So, I'm looking at the whole pattern. I'm looking at your clinical picture, agreeing or accepting, acknowledging that there's uncertainty associated when we test someone is something that we all need to do, especially with these tests as they're developing and we're still learning so much about them. Now, this is another thing that we did, and I promise you, as I always do, I will break it down. Okay, so there are four panels on the screen, A, B, C, D, and we will look at one panel at a time. Now, this particular panel is made to look at a question that will really be very interesting. This is looking at you see that every particular panel has a blue dot and a red dot. Okay. The blue dot is what we observed in the data set. But as I said, we also model the data to say we were trying to see the probabilities. So the red is the matching, we were just looking at it, right? And we found that it was matching very close to the blue observed data. But again, it's pretty overwhelming as a whole picture. This panel is for amyloid beta 42 by 40 plasma ratio. And on the top panel, we are looking at what happens when PET and CSF disagree, what happens when PET and plasma disagree. So that's the panel B. Then you look at C, CSF and plasma disagree, and D, when they say that we are not sure because the blood test also says that they're not sure. There is an indeterminate area or category. So this is all for amyloid beta 42 by 40 plasma ratio. And we have very similar looking results for p-tau 217 as well. So we will now do parallel analysis. And before I go into that, you do see that every panel has three numbers. Well, we will only look at the first column, so to say. Why? And what are these numbers? So the first particular column that you see in each panel, the red and the blue dot that are together, that is if you did the test less than 7 days within each other. So say if I was worried about Alzheimer's, I did my PET scan, did my CSF within 7 days of each other. You would think that they agree 100%. Well, they don't. But we'll look into that. The second part or the middle column that you see the blue and the red, that's when you look at 7 to 30 days or 8 to 30 days, sorry. And then the last one is more than 30 days. So, here we were questioning actually that if you collect these two tests in pretty close time period of each other, are they agreeing? Or even then, they're not agreeing. And you have to think about that as well. So let's now look at it in this way. And I'll again orient all of us to what we are seeing here. So on the very left, you have plasma amyloid beta 42 to 40. And on the right, the panel is for p-tau 217. And here, actually, we are mostly looking at the PET and CSF disagreement. A person gets the test within 7 days. Think about it. If you are a patient, think about it. If you got both the test, you would think they would agree, right? Because the whole description that I gave could have just been explained by a simple thing. Well, someone got a PET back 2 years ago, it was negative, and then they got a CSF more recently, and now it's positive. So you may have reasoned out, well, the whole thing that we have discussed up until now could just be explained by time. So we're trying to look that if that's the case or not. That's the reasoning to look at these graphs, okay? All I want you to focus on when we look at this graph is the very first panel. That is less than 7 days of two tests being done. Which tests? PET scan and CSF. Look at the blue dots. Where are they? So the discordance is the disagreement between these two studies is low. It's about 12%. It seems like a pretty low number, right? Out of 98, only 12 patients had a discordant result. Their PET was positive and CSF was negative, or CSF was positive and PET was negative. Well, that's 1 in 8. That's not a small number. They were done within the same week. Imagine you worried that you have Alzheimer's. Your doctor is testing you. You get a PET scan and CSF. They don't agree. That's not a small number. And if you look at the real N number that we have, 12 in almost 100 people will have studies that don't agree. That's important to know that this is something that these studies don't agree. And we've talked about many reasons, right? They don't even look at the same exact substrate of amyloid. So they don't agree even when you do the studies within 7 days of each other. Now, what our model predicted, and this is for PET scan and CSF, right? What our model predicted here, and this is something that I do want to emphasize, 1 in 8 PET and CSF will not agree, even if you draw them within 7 days. This is so important for you to understand as a clinician, for you to understand as a patient. And you might be making the wrong diagnosis. So imagine if you were a patient or you were a physician and you offered your patient a choice. Would you like to do a CSF? Would you like to do a PET? What if they are that 1 in 8? Think about it. Are they interchangeable? Not really. They don't agree with each other 100%. So in the field currently, we do offer them as, would you like to have a lumbar puncture? Oh, well, some people are not liking the needle, so maybe you can get a PET scan. It's not to be offered like that because they're not interchangeable. That's just the science part, right? But then there's the art of medicine. Some people are fearing the needles, then they have to go to the PET scan. What I'm trying to say is not that one test is better from another, but they do disagree sometimes, even if done very closely in time. So you might get a test that is saying negative, but the other one might be positive. So you might get a false reassurance that I don't have Alzheimer's when the other test could have shown it was positive. But also think about it from the perspective of your physician. They're also as lost as you are because this is a limitation of the testing. So think about this. Now, 12% were discordant, not agreeing between PET and CSF, as we said, within 7 days. What our model predicted was that if you use the amyloid beta 42 to 40, the discordance was a little higher than if you looked at the p-tau 217, but they're pretty close. Now we will look at other things. So here we are looking at, and again, let's orient ourselves. We are now on the panel B of the same figure. We're now comparing again plasma amyloid beta 42 to 40 on A, and on the B side, that is on the right side, you're looking at plasma p-tau. Again, all I want you to look at is the blue dots on for both of them in the extreme right, extreme left of both panels, because this is within 7 days. What is it actually answering? It is saying if within 7 days I got myself tested with the blood test and I got a scan, the PET scan, how much are they in agreement? That's what it's asking, right? Are the blood tests agreeing with PET, whether it's positive or negative? That's the question. But I've highlighted on the top of the graph determinants. So remember when we looked at the blood test, it said high, low, and indeterminants. So here we're just looking at high and low. When the blood test is kind of saying, well, I think is a high likelihood or I think it's a low likelihood. Either way, we are trying to see which, when the blood test says that the probability is low, is the PET also negative? Or when the blood test says the probability is high, is the PET also positive? That's what we're looking at. So this is the discordance. In persons who get amyloid beta 42 to 40 ratio, the mismatch is about 17%. So for 6 out of 36 patients, actually those two tests did not agree. One was positive, one was negative. Look at p-tau. Look at the blue dot in p-tau. It's close to zero. Sorry, p-tau to 17. It's close to zero. What does that mean? That means that there was no disagreement. So if the PET said that the person had Alzheimer's, the plasma p-tau to 17 also gave a high likelihood of having that positive. So they agreed a little bit more than when you do amyloid beta 42 to 40 ratio. That's good. That tells us that p-tau performs better. We've known this. There are recent studies. There's work from Dr. Snyder. She has given talks in A, and we know p-tau is better than amyloid beta 42 to 40. And we have talked about it on our channel in the past as well. The mismatch between the blood test and the PET scan is 0 out of 39. Of course, these numbers are low, right? And we will come to that because some of you might be wondering, well, that's 39 patients only. That's not a big number. Well, I'll come to that and we'll talk about why that number is low. But this is when the plasma is claiming, the blood is claiming this person has a low likelihood or a high likelihood, right? And they pretty much agree when we look at those numbers for both of these. Now, what about the agreement between blood test and CSF? If you do these tests within 7 days of each other for plasma amyloid beta 42 to 40 or plasma p-tau 217, and you're just looking at determinants when the blood test says low or high likelihood, you're just looking at those numbers. You're not looking at the indeterminants, right? How do these tests perform in relation to each other? Well, again, for amyloid beta 42 to 40 ratio in the blood, it kind of does not always agree as good with CSF as does the p-tau. P-tau is almost agreeing completely, right? There's no mismatch for p-tau 217. Again, we have talked about it. The field has noticed this, that p-tau 217 is a better marker for kind of predicting the amyloid in the brain. So that matches. We have known that. For determinants, that's again saying I'm giving you a low or high likelihood on the blood test. Overall, p-tau has a better performance as compared to plasma amyloid beta 42 to 40 ratio. We've known this. And this is interesting to note. And that's the key takeaway when your blood test is able to say low or high. But do you know, and you may have already come into, I see these questions and conversations on Women's Neurology group on Facebook where their patients have tested intermediate between the blood test. So the blood test sometimes can just say, I don't know. So it can give you a middle kind of probability. Now, again, I know this is, we have 4 dots now instead of 3 dots, but I'll orient you, I promise. So again, I want you to look at just one graph because otherwise it can get very overwhelming. I want you to look at just the blue circles, okay? The blue circles are the observed data, and the red is our model's performance, the red squares. And throughout this whole panel discussions, you've seen that our model is doing a great job at predicting. But look at the blue circles. The first one is the kind of uh, kind of representing how much with the full circle, right? There's a full blue circle and there's an empty blue circle. So the first one is between PET and blood for amyloid beta 42 and 40. And it says that there's pretty high discordance, right? You see that they're not matching. They're pretty high on that graph. And the CSF is also pretty high, kind of similar. But to put it into clinical context, when PET is having a result and plasma says, I don't know whether it's high or low risk, that number is 60 out of 96. So 63% are intermediate for, or indeterminate actually, for PET and plasma. And this, you see that they're not agreeing now because the blood test doesn't tell you whether it's thinking high or low risk. Fine, that kind of makes sense because the blood test should have told us high or low, likelihood. But here it is saying, I don't know, it's intermediate. And so that what is important here is now look at the numbers. 60 out of 96 patients had indeterminate results on their blood test. Is that a small number? No, 63%. That's a big number. So when you test people with blood, there is a high likelihood of them getting tested in between. And then you're like, I don't know what to do with this. Again, when you look at CSF and plasma, 75 of the 117 patients actually had intermediate results. And so the discordance is worse when you have the plasma is also unsure. The plasma results is also intermediate. But remember the other graphs where we were seeing, and I said, well, you might be wondering the numbers are low, just 36 out of 96 and 42 out of 117 for the different panels we have done so far. So look at those numbers. 96 is the total number of patients who had the PET scan. And this is the total number of patients out of those 96, 60, that's shown in the blue on the top, 60 out of 96 were indeterminate or intermediate. We don't know what they have with the blood test. only 36 was determinate with the blood test. So the blood test is not as good if you start paying attention to the numbers of people who don't get a determinate test. We have known, and this aspect has been ignored throughout the approvals. That's why the blood tests look so accurate. They're not that accurate because when they try to calculate the accuracy, they are removing these patients who are intermediate. You cannot do that. You cannot remove intermediate. These people are 63 and 64. And I have another publication coming on that. What to do with intermediate, how to calculate. You cannot just take out a piece of results and say, well, because we did not know, we are not calculating the accuracy based on those numbers. That's not how it works. So pay attention to these numbers. The lower number that is in blue, 75 out of 117, we did not know what the blood test was saying. It was indeterminate or it was intermediate. 42 were the ones that were determinate. Again, the number that the blood test is able to give you as high or low risk, which is what you want, right, is lower. This is for plasma amyloid beta 42 to 40. What happens with p-tau? Because so far we've been saying, oh, this one does better than amyloid beta 42 to 40. Well, the numbers are also very high for these people. So PET and plasma, when you do people who have about 96 people got the PET scans, right? Out of them who have also had the p-tau to 17, 57 patients out of 96. Think about that number when you see your patients. 56 out of 96. 57 out of 96. The blood test is intermediate. So it's not helping you a lot if you just do a blood test like that. CSF and plasma. When plasma is intermediate, about 67 patients out of 117, the test was intermediate. And if you look at the numbers again, which one were determinants? Out of 96, 39, the blood test could say positive or negative or low or high risk. But for 57, it said, I don't know. Similarly, for when we compare CSF and plasma and we look at those numbers for these patients, we see that out of 117 people who had their CSF drawn, 67 had a blood test that meant no information. It was intermediate. 50 had the information which was determinant, which was helpful to the clinician, to the patient. Again, the way the blood tests are reported, every single one of them, they're not reporting these intermediate patients. And if you notice, these intermediate patients are more than 50%. So what are we ignoring here? It's a huge population. It's not like less than 1% or 20% or something like that. In this, at least in this data set, this number is more than 50%. So we cannot ignore these patients and these numbers when we calculate accuracies of plasma p-tau to 17 or amyloid beta 42 to 40. So far, the calculations I've seen have taken away these patients. They've not accounted for these patients. And that's why you hear, oh, the blood test, 99% accuracy. Wow. Statistically, you cannot remove people where you are uncertain. You have to account. And if it reduces your accuracy, accept that. So the key takeaway here is both p-tau and amyloid beta 42 to 40 ratio for the blood test have majority, more than 50%, that are indeterminate. This asks clinicians to express that I cannot say 100% this or that. I have to talk about probabilities. I have to look at the pattern of the three biomarkers. We just cannot, because these tests are, when you look at the reports and when you look at the news releases, all of them say we are so accurate. Well, we cannot remove the indeterminates. And if you keep them in and you think about it, the test is not as accurate. And you have to just kind of take into account that's okay. No test is 100% accurate. That's fine. I don't expect any test to be 100% accurate, but I cannot also fool myself or convey that with that certainty when I'm talking to my families or I'm thinking about it scientifically. So the summary here is we should not ask this question about which test should be the ground truth, at least with this data and with our exploration. And it's a time to ask the better question, which is when they do not perfectly agree, we should not be forcing certainty. As a clinician, this is my day in and day out. And it is the worst thing. If I have a test that does not mismatch, or if I have a test, one test says this, the other test says that. But if I am there, I have to agree. And that's nothing to do with my credibility or the ability to interpret things. It is just the way the tests are. Only if we agree and acknowledge that there are some issues will we improve and we will be able to convey that uncertainty and to think about multimodal testing, right? These are three biomarkers, multimodal testing, thinking about probabilistic reporting, and thinking about patterns. That is the approach and the future of biomarkers for Alzheimer's. And for more information, again, I'll share my paper here, and I have a couple more publications coming in the same regard, thinking about biomarkers and how to properly interpret, understand, and apply them in your clinic. And if you're a patient, how to understand that there are uncertainties. This was a fun session. I had a lot of fun doing this.